Good morning. Welcome to this Global Health Unpacked seminar. My name is Katarina Storeng, and I will be moderating today's session. This seminar is organized by the Global Health Politics Group here at the Center for Development and Environment, the University of Oslo, in collaboration with the Center for Global Health and Women Global Health Norway. Today, we're very happy to welcome Professor Sophie Harman. She is Professor of International Politics at Queen Mary University of London, where she teaches and conducts research into global health politics, African agency and international relations, and visual politics. She's also an acclaimed filmmaker, and in 2016 co-wrote and produced her first narrative feature film, Philly, which was nominated for a BAFTA and is highly recommended, really. Her first book for a popular audience is on the centrality of women's health to international politics. It's called Sick of It and will be published in July, on the 4th of July, to be precise. And today we're going to have a preview in the seminar, which is titled Hijacking Women's Health. Welcome, Sophie, and we look forward to hearing about.
Thanks so much.
Afterwards, there will be a Q&A, so please prepare your questions, and you will be invited to post them to the webinar. Thank you.
Thanks so much, Katarina, and thanks everyone for being here so early and joining online. It's lovely to see everyone. I want to take you back to February 2020. Sorry, yes, perfect, thank you. I want to take you back to February 2020, which is possibly a time no one wants to go back to. But at that point, I was in Freetown in Sierra Leone, picking up on research of what happened to women during the Ebola crisis in 2014 to 2016. And during this time, I was talking to people. They were telling me about how domestic violence had gone up during quarantines, how there'd be a higher rate of death because of pregnancy-related complications rather than from Ebola itself, how women suffered as frontline community health workers, how they weren't given adequate PPE, and how there'd been an increase in teenage pregnancy. What was also notable was how women leaders had flagged these issues during the Ebola crisis and were routinely ignored or told that there was no time for that this is a crisis. While I was doing these interviews and sort of running around Freetown, my WhatsApp was pinging with friends talking about what was happening with COVID-19, that we were then still calling the coronavirus, not really knowing what was to come. I had friends going on the radio saying, what shall I say? No one's taking this issue about women seriously. And there was a sense that something was happening at that point. I think people weren't ignoring COVID-19 as much. And then there was one day that I walked into the Ministry of Health in Freetown and was presented with a thermometer gun. So something that was very common during the Ebola crisis that read your temperature. I was asked to wash my hands. And then I had that sudden thought of, oh gosh, here we go. The World Health Organization declared COVID-19 a public health emergency of international concern. And I had this real sense of foreboding about what was going to happen to women. We didn't know where it was going to happen to women, but it was like being faced with this iceberg of knowing what happened to women during Ebola and what might happen during COVID-19. And of course, when you started to talk to people about this, they're like, oh, but that happened in Sierra Leone. That won't happen in other countries, which you can unpack for all really different reasons. And there was a striking thing that how do you stop the same thing happening again? What do you do with all this knowledge that you accrue as a global health politics expert, as a women's health expert? How do you stop it happening again? And then the more I was sat in Freetown thinking about what was happening in the world at that time, I thought there'd been decades of international prioritization around particularly maternal mortality in countries like Sierra Leone, but still women were dying every 2 minutes because of pregnancy and childbirth related complications. In international relations, everyone was very concerned about what Donald Trump was going to do with China, how he was going to respond to COVID-19. But also, no one was really talking in international relations circles where I sit about the global gag rule or what Trump was doing to women's health and the sanctions that he was putting on women's health in the world. There were bubbling scandals in the global health community about sexual abuse and exploitation of women. And there's a sense of overburdened and broken health systems resting on the free labour of women. Increasingly, there were attacks on maternity hospitals in conflict zones such as Syria, and now as we see in Ukraine and Gaza. And post the Me Too global health moment, there was this excitement, and it's great that I'm being supported by women in global health here in Norway, that the solutions were let's just add more women and the problems will be solved. But there was no kind of stepping back of this kind of wider politics. So I thought, what is actually going on here? How do we make sense of all these different things that are happening? How do I get over my existential crisis as an academic? You can't do anything to change what's about to happen. There was a feeling that things were getting seriously worse for women in the world, and that there could be something that connects all of this. So how I made sense of this is I wrote a book about it. I wrote an academic book. It was very, very different to the book that I've come up with now, and I scrapped the whole thing. So I have an academic book that's sitting in an unloved folder, and instead I've written a popular book, a kind of trade version, which, as Katerina said, it's called Sick of It, and it's coming out on the 4th of July. And this book really tries to connect the dots, and it kind of has two main arguments that I'm going to present here today. The first one is women's health is major political currency in how governments, international organisations, companies and NGOs gain and sustain power in world affairs. That's a big one. This currency works in two ways. First, through the exploitation of women's health as a political issue, and second, through the exploitation of women working in the health sector. So those are the two ways. The big thing is exploitation is not just by the usual suspects you would automatically think of, so your kind of Trump, your Bolsonaros, your kind of right-wing populists or activists, but also the very people who claim to be advancing women's health. So this is possibly a more controversial part. What gives women's health such power is it is overlooked as a tool of foreign policy. So people don't, it's sort of about development. You know, the amount of times I've done these talks and people in international relations go, oh, I don't really do development, or I don't really do health. This is what I'm trying to say, is like, no, it's so much bigger than that. And similarly in health, people say, oh, well, I don't really do women, or I don't really do power. So it's really central to foreign policy. It's not a second order issue of international relations or development or soft power, but is at the heart of how global politics works. And for me personally, cuts to what international relations is about. It's about women dying when they don't have to, and how we stop that from happening. So I'm going to outline this argument in 4 parts, and then I think I'm going to set out what comes next and a research agenda. So first part. First part, I want to start by centering women's health in global politics and bursting 2 popular myths. And I think these are really important for us to move on. The first myth is the lack of attention or political will that women's health gets. Women's health gets lots of political attention, gets loads, it's just the wrong kind. First, the most obvious, there is a major political will to control and curtail women's sexual and reproductive health. And this has existed throughout history. This is nothing new. It's always been a core part of politics, where the kind of natalism, nationalism, state building, its role in conflict, it's all there. Also in global politics, women's health is one of the issues that world leaders could all agree on. There is a clear political will to act on addressing some of the major killing of causes of death of women during the end of the 1990s and early 2000s, when you saw this shift away from macro structural adjustment to looking at human development issues, most obviously encapsulated by the Millennium Development Goals and the Make Poverty History movement. And 2 women's health issues were at the heart of this, so maternal mortality and HIV and AIDS. You could also say potentially under 5 child death as well, because obviously that is related to maternal mortality. And this is continued into the Sustainable Development Goals. Now, of course, within that, there is criticism of what counts as effective strategies of maternal mortality. And we can come back to that, and Katerina's work's been great on that. And also there's the criticism that of all the Millennium Development Goals, maternal health didn't get as much funding as other issues, but there was a general political consensus. So this idea that everyone disagrees or, doesn't prioritise women's health is a fallacy. But even when there are aid budget cuts, there's also one of the justifications of keeping aid going or committing to this 0.7% is we need to save women and children. So women's health comes back all the time. And even in the UK context, where we see aid funding being cut and debates over aid, politicians always use women's health as a reason of Britain's values in the world and Britain doing good work in the world. And once you start to see this, you can't unsee it. It starts happening quite often. Even this week in the UK, when we've had the report on birth trauma within the UK, again, you can see that's sort of Rishi Sunak positioning this within an election, saying, but I'm going to do something, I've done this report, ignoring the underfunding of women's health in that respect. So we need to actually be attuned to the type of attention women's health gets and who it serves. So instead of saying it's ignored, actually there is attention there. So that's the first myth, that it gets no attention, it gets lots. The second myth is women are invisible. Now, this became very popular with Caroline Criado Perez's book, Invisible Women, which is a great book. If you haven't read that book, really recommend it. It's a really great book. And it's all about bias and science and data and blind spots in data. So it's a great book, but it's a fallacy to say women are invisible, particularly in international relations and particularly in women's health. Health is a highly feminized sector. We know that women make up 70% of the health workforce, and this doesn't even account for the informal labour and community health work that happens and underpins global health programmes. We see them in high-profile roles, so obviously, very typical this week, with Melinda French-Gates being one of the most powerful people in the world, Margaret Chan, who's the Director General of the WHO, and Natalia Kennan from UNFPA, who are always rolled out to me when I say there's no women in leadership roles. They're like, what about Margaret Chan? You're like, right, okay, feminism solved. But still, the problem is men decide and women deliver, and that's very much Women in Global Health have done a lot of work on this, and the group Global Health 50/50 sort of map what's happening in institutions, looking at women lead 40% of most influential health organisations in the world, but 9% of those are women from low and middle income countries, and only 1% is a woman from a low income country. So there's a huge kind of mismatch there. And that was kind of bothering me when I started to talk about this invisibility. It was quite popular, everyone was talking about it. And in 2016, that's when I came up with the idea of conspicuous invisibility. How you have this conspicuous nature of women within the health sector, dominating health work. You go to any hospital, any community health work, that's what you see, but they are invisible from leadership positions. And this is very deliberate. They are conspicuous in the work, they're invisible in the policy documentation. So originally I developed that idea in 2016 during the Ebola crisis, but actually the more I think about it, the more the concept has been applied by others as well. And this is deliberate. This is a deliberate invisibility. Politicians know women in the majority of health workers. They know they're doing the community health work. World leaders in global health know this. They don't pay them, even though they say they're going to pay them. That doesn't happen. And these women are hugely exploited. They're underpaid, they work for free, they're burnt out, and they're also subject to frontline violence. So in the book, and I'll talk about this in a bit, I look at violence against healthcare workers as potentially a form of gender-based violence because who it affects and why it isn't addressed. And why I think it's important then to rethink these two myths, to start with these two myths, is I think the invisibility myth reinforces an unequal ontology. We choose not to see these power relations before us. In reinserting this invisibility question, we continue to exploit women who work for free for million-dollar aid programs, and we ignore the spaces and politics in which they operate because we're not looking. If we actually think about where women are instead of always focusing on where they aren't, then we miss a lot of these power relations. They're not invisible, they're at the heart of these power relations. And in thinking about this invisibility, it then leads to these instrumentalist solutions of add women, more women leaders, more women's visibility, and therefore women's health will improve. Now, I'm all for adding more women into senior leadership, brilliant. But it's obviously, I don't think it'll then lead to more gender equal outcomes because I've been studying feminism for 20 years and feminist research suggests that doesn't necessarily happen. So we're not addressing the political problem of how women's health is exploited in global politics, and therefore we need to move beyond these instrumentalist arguments. Okay, so now I've busted those myths. How is women's health exploited? So obviously, we'll start with the obvious one, sexual and reproductive health. And all my friends are sort of like, yes, your Roe versus Wade book. No, my book is more than that. But of course, when we think about how women's health is exploited in global politics, you would think about abortion. Abortion and modern contraception, it's often an ignored partner. And yes, of course, abortion and reproductive justice have always been a big part of politics. It's a core driver not only of states trying to curtail women's health, but also of transnational feminist movements and organising, representation of women in the United Nations and wider multilateralism. So I think that's often something that we ignore, how that kind of boost for reproductive justice led to a lot of institutional creation within the UN and change. But also we know that for every advancement in women's health, particularly around sexual and reproductive health rights, we're faced with backlash, and we're seeing that at the moment. And we know this from Susan Faludi's work around backlash. I think it was published like 30 years ago, with Dorothy Roberts' work as well. These books have existed for a long time, as researchers existed for a long time. And what's important here is, like the patriarchy, how abortion works as a tool of foreign policy and domestic policy shifts and changes. It changes as politics changes. And we can see two main trends, I think, in how this works in contemporary IR. Is this okay? That's fine, I'll keep going. So the first one in how this changes in contemporary global politics is obviously the role of abortion and sexual and reproductive health rights in anti-gender ideology and contemporary populism. So this is where abortion, feminists, reproductive justice are all parts of attack on traditional conservative values, family, and a nationalist claim to an idealized past where we knew who a man and a woman were and what their roles were. And the problem in contemporary society is not mismanagement of an economy, austerity politics, or foreign policy, but it's this. It's feminism, it's abortion, and it's a breakdown of traditional family values, whatever that is. And it's part of a wider ills of decline of a country, and often is blamed with bedfellows of LGBTQ+ rights as well. So far, so common, we know that this is how these issues are mobilised. What becomes particularly persuasive about women's health and abortion in this anti-gender ideology is how Elżbieta Korolczuk and Agnieszka Graf have argued it plays, and also if you've never read their article, Ebola from Brussels is a great article. I am like a woman campaigning for this article. It's Gender is Ebola from Brussels, so it's all about anti-gender ideology. It's brilliant. But they argue why it's so effective. It plays on colonial history, the language of decolonization, and the external other trying to control or curtail women's lives. So this is what new about it. It takes the language of the decolonization movement, that type of thing, and actually adopts it to advance these kind of ideas and interests. Why this is so effective is first that controlling women's sexual and reproductive health through forced sterilisation and population control was a tool of colonial rule and did happen. It's a past that has not entirely been acknowledged or reckoned with, particularly in global health and particularly in the global north. So you can exploit that. This is how you see these kind of anti-gender ideology exploiting that there's some truth in this. The second part is what Sarah Davies and I have called the silent security dilemma for those working in sexual and reproductive health. And with this, Sarah and I wrote this paper, really drawing on Katerina's work on this, which is great, is that what you see this silent pact that then enters because of these kind of histories, where health ministries and abortion providers go about their business to try and reduce maternal mortality in a country by providing safe abortion. But they call what they do post-abortion care, or they say there's a kind of sleight of hand in how they kind of label it, because as long as no one calls them out, it's absolutely fine. So they know that there's this silent pact that happens, but that silence can then be exploited. You can say, look, those NGOs, those foreign NGOs are up to no good, we told you, because they were keeping it silent. So the silent pact only lasts. This is the security dilemma. It holds until someone calls it out. And as your work shows, when someone calls it out, that can be really dangerous for all involved. And it's exploited. These loopholes and gaps are exploited, and it's exploited for votes, and it's to keep international interference out and to frustrate multilateralism as well. And all of this is given enhanced power by a second trend in using abortion as a political tool, abortion and global economic sanctions, aka the global gag rule, of course. Now, the global gag rule is not new. It's pretty much as old as I am. It's 40 years old. I'm 43. But it's the global gag rule, aka the Mexico City policy, was passed by Ronald Reagan in 1984. For those unfamiliar, it's the rule that any agency receiving funds from the US federal government cannot provide abortion services or be seen to be promoting abortion. Every Democratic president reverses the rule, every Republican president extends the rule. So with Trump, he extended the rule to not just cover NGOs, but all aspects of US global health funding. So it also applied to the UN, so multiple partners and agencies. An example of the impact is under George W. Bush, it applied to $600 million of funding. Under Trump, it was $9 billion. Now, we saw when this happened, when the global gag rule came back under Trump, that certain countries stepped up and said, we're here in Norway, so we will try and fill the gap, but of course that is a huge gap. That money is really important. If you then add in Trump's evocation of the 1985 Kemp-Kasten Act, which allows the president to stop funding for any organisation he deems in supporting involuntary sterilisation or coercive abortion, that means all cuts of funding to UNFPA. Even though UNFPA wasn't doing it, he deems it's happening, therefore you can cut it. Now, what I think is really important about the global gag rule is it is an economic sanction. it's a sanction. It's also withdrawal from global health governance, so it's using women's health to withdraw from global health governance, all off the back of women's health. It's an as with all sanctions, it's an economic sanction that affects the most vulnerable and people who are most vulnerable in society. It's effective because other states that want to curtail sexual and reproductive rights want to get behind it. It undermines multilateralism and global governance, and it appeals to global populists. It goes unaddressed in sanctions work, in international relations and international economics. It gets completely ignored, even though it's one of the biggest sanctions the US has in the world. And my argument around it is it's not just, abortion is not just a domestic policy issue, it's a global policy issue. And this might sound completely obvious. I imagine it sounds really obvious to people in the room today. But when you ever go in international relations and international development, or you look at any policy and you hear people talking about sanctions, hard power, foreign policy, populism in the world. And there was a period where I was editing a journal and we had so many articles on populism in world politics. None mentioned women's health, none mentioned sexual and reproductive health. And outside feminist circles, and even in IR feminist circles, you didn't even hear about the global gag rule. And it's all because it's who it is affecting. Okay. So let's just think about the positive now, right? So this all seems a bit doom and gloom. So the other thing about why women's health is so effective is because it also can tell a positive story. It's not just populist and anti-gender ideologists that are using women's health to advance their interest in the world. It can also happen in positive currency. So the international community, most obvious way, justifies aid in the work it does off the back of saving mothers. And in turn, states develop their diplomatic relations and their standing off the back of women's health. Before we get to this slide, this beautiful image that you can see, I always say, guess where it is, and I have a photo credit. So there you go. Do you all know where the University of Global Health Equity is? Yes, good. Okay, so we're looking at Rwanda, but I'm going to come back to Rwanda in a minute. First, I just want to say how people use this positive currency more generally in global politics. If you think about it, institutions use the primacy of health and the work they do to defend and maintain an institution, especially when they do something wrong. They never do men's health, right? You never see institutions saying we're saving this number of men. It's always we're saving this number of women. Two clear cases of this recently. First, with Médecins Sans Frontières and controversy over the sale of images of vulnerable women and girls seeking care in health facilities. Second, the case of sexual abuse and exploitation of women by staff related to the Ebola response in the DRC, some directly related to the World Health Organization. Two very different cases, but similar in some of the defences. If you criticise what's going on here, you're going to stop us doing our vitally important work, and that vitally important work is saving women and girls. Right? That's the first way that happens. Second way it happens, and this was particularly acute with the WHO and the sex abuse scandals, what you saw was suddenly women in the institution coming out to actually defend the institution. And that was obviously a deliberate tactic. During this time, you always would see Tedros flanked by women and powerful women coming out to explain what was happening as well. This is really important because there is a sort of sense that we are the good guys. We didn't do anything wrong. Something wrong happened out there. We're the good guys that help women's health. And Megan Daigle's work on stranger danger is really important here. So if you look at lots of the kind of policies, the idea is the danger is out there in the field. And this is re-inscribed through some of these kind of defensive mechanisms as well. So that's the first instance of how you use, no, we're doing the good stuff. Therefore, yes, there was a mistake, but just ignore that. Otherwise, if you criticise us, our funding cuts, that's the problem, women will die. In the second issue, so the second instance I want to concentrate on is how women's health is the most effective way in which you can wash the reputation of the state, so health washing. This is what brings me to Rwanda. Women's health is an incredibly effective source of soft power and diplomacy. Rwanda is an authoritarian regime that kills and disappears opposition politicians and cracks down on the media and external criticism. Okay, I think this is pretty much accepted. If not, okay, I can give you a reading list, but that's fine. At the centre of global health, but it's also a major donor darling in global health. There's a very strange dissonance where you read about Rwanda and then you go to a global health meeting and everyone's like, Rwanda, right? And this is very important. This is not an accident. This has been carefully cultivated and crafted by Paul Kagame and people working in the health sector. And also, the Rwanda's results in health, some people say the data is, but okay, if you look at the data, 85% reduction in maternal mortality, 70% decline in under 5 child mortality, 45.1% of women being able to access modern contraception, 80% of people living with HIV on antiretroviral treatment, all led by a charismatic woman, Agnes Biginawahu, who was also helped set up the University of Global Health Equity, quotas for women to make sure women are represented at every level, women in global health leadership program. It's like a feminist utopia, right? And that is how it's been designed to seem. So this is great. And this is a tricky one, because that is fantastic. This is all a post-conflict country that had absolutely no credit rating on international markets post-genocide, does all that, right? Fantastic, like you can't take away from that. However, it is effectively used to deflect wider attention away from Rwanda. And why it works. Success stories connect with a positive image of a state and the aid sector in international relations. If you think around the Millennium Development Goals around 2015, those sort of results, most of the international community were absolutely dying for, like they were wanting those results. I did work in Tanzania and Zambia, and they were sending people from the Ministry of Health to go to Rwanda to learn how to do it the Rwandan way, right? And there's lots we can learn from Rwanda. I was like, why don't you send people from the UK to learn from Rwanda? But also why it works, and it's an effective form of soft power and diplomacy, is it involves social justice leaders, notably Paul Farmer, hugely recognised in the world as the good guy who's very progressive, Partners for Health. Everyone respects Partners for Health. It's partnering with Rwanda. Bill Gates, biggest philanthropist in the world. They all support a state that they would otherwise criticise. And it's effective because they're getting these results on women's health. So women's health, but ultimately women's health becomes the ultimate deflect and switch. And if you criticise Rwanda, you're like, okay, well, you're a genocide denier, which I'm not doing. The genocide in Rwanda happened, especially in 2024, so we're at the anniversary of the genocide in 1994. But also, if you don't like what Kagame doing, who cares? Look at what he's doing in women's health. It's the ultimate deflect and switch in how you wash a country, right? It's so effective, I don't know why other countries don't do it more. Not the same, not that I'm advocating for this, but it's really effective. It also is effective because Kagame and Rwanda have much bigger power in international relations as well. I always think Kagame understands international relations better than lots of leaders in the world, and he knows exactly what he's doing. Don't know what you think of this, but I probably agree. So we'll see. Anyway, but the bigger problem is, Rwanda is not the only country that does this. The other big example of health washing is Israel. Israel is a country that boasts the best IVF in the world, says it's equal to the US, but is better in terms of it's more affordable. It guarantees 2 children. It had the first and the fastest rollout of COVID-19 vaccines. If you read Albert Bourla's book around Pfizer and the quest to get the COVID-19 vaccine, he calls Israel a beacon of hope, right? So he's very pro-Israel and Israeli health system. Now, why do I talk about Israel and health washing? Well, obviously there's the other side of the story of what Israel is washing itself. All right, sorry, I have a pause. Okay, time. Okay, I'm coming to pause there. Okay. All right, so the other thing to think about is the role of women's health in conflict, which increasingly you see the women, peace and security agenda that doesn't really think about women's health. You see medical humanitarianism that sort of thinks about women's health, and you have global health security. And sometimes these 3 bodies talk to each other, but they have run across different policy interventions, different laws. How do we make these 3 different bodies talk to each other? So to take a step back from that, in November 2022, I was engaging the final parts of the research of the book by talking to health workers in Palestine about the rise in C-sections among Palestinian women and the issue of giving birth on Israeli checkpoints. So this is 2022, so it's before October 7th, and what we see is happening now. Dating back as far as 2008, the UN was so worried about what was happening, they issued a report outlining 9 serious concerns about Palestinian women's access to reproductive health care under Israeli occupation. What they saw was C-sections were increasing because they were becoming a logical solution to the problem that pregnant people were facing. How do you control your birth under an occupation that limits how you move to health facilities? You don't risk it, right? So if you can only get a permit, particularly to leave Gaza, or you have a permit to move, You need that permit, you can only get it 2 days before you're meant to go to the health facility. If you're giving birth, how do you ever predict that that's going to happen? So you book a C-section to give it an element of prediction. You sort out your paperwork. This is a problem in the West Bank, but it's even more acute in Gaza. So between 2008 and 2022, the WHO reported a total of 3,815 interrogations of patients requiring permits to cross out of Gaza. 28 patients were arrested seeking healthcare, and 64% of health worker permits through the WHO were denied. So the WHO, so like this is not a Hamas-run health authority or Palestinian authority, this is the WHO. A third of all permits for regular healthcare travel were denied or delayed between 2016 and 2022. So this is even if you can get a permit to travel. And then of course, travel within Gaza and within the West Bank, you can have ad hoc checkpoints as well that will stop you from traveling. Even more alarming, due to restrictions on who could or could not have a permit, 43% of children seeking access to healthcare outside Gaza from 2018 to 2022 travelled without a parent. So that's 43% of children travelling without a parent who need healthcare. When I was doing research for this part and looking at Palestine, what was happening with what's now commonly called obstetric violence, was that this was a slow way of defeating and diminishing Palestinian lives. And it's a slow burn of we are going to control your bodies and how you can reproduce. And this work has been developed by Lydia Wick, Tiziana Leone, Rita Hijacking. So it's a kind of common thing that's understood within women's health within Palestine. So this is like the slow burn of the conflicts. And you have lots of people writing on Palestine, we'll talk about this in other ways, but this is very much acute within healthcare. And in the book, which I kind of finished and submitted in like September last year, I juxtaposed against the slow attack against what was happening in Ukraine, where you saw direct targeting on maternity hospitals. Now, of course, we've seen this happening in Gaza following the Hamas attacks on the 7th of October. And I just want to pause here because I think it's depressing, but it's worth pointing out again. At the start of the conflict in Gaza, 50,000 women were pregnant. And then I read this piece within the London Review of Books. I'm going to quote directly by Azadea Moaveni, that since the war began, many of these women miscarried or had stillbirths. Since proper medical care is non-existent, women often go into labour in the dark of a tent encampment, aided by mobile phone, flashlights, or undergo C-sections without anaesthesia. Even before Israel's starvation campaign reached famine levels, insufficient calories and continual bombardment made it difficult for women to breastfeed. A UN team recently found that no babies of normal weight are being born in Gaza, and many babies, according to the World Health Organization, are simply dying. I think we know all this, but what's really important about this article is how, when people are talking about the conflict, you saw it in South Africa's submission to the ICJ, but otherwise, actually, people aren't talking about it at all. So these women are just giving birth in tents and doing what they can with their babies severely malnourished. Now, what I want to say in Ukraine, Syria, and Gaza, obviously, you saw the same playbook. First, you attack a maternity hospital. Second, you say that wasn't us, it was the other side. And when that doesn't work, you say, well, there are terrorists there and they did it. Oh, no, sorry, we did do it, but there are terrorists there, which is obviously a core part of international humanitarian law, the big loophole in international humanitarian law, the Libor Code, that if you think that your enemy is there, then that's fair game. Then you have the fourth part of like, okay, we did do it, we'll bring aid. So everyone saw that quite visibly on Twitter with the Israeli Defense Force bringing aid into the hospitals. I think it was like labeled aid or medical help. And then we'll do it again. So it's the same playbook. The only difference that you get from Ukraine, Syria, and Gaza is the EU and America were straight to condemn Russia in Syria and Ukraine, and they have not done the same in Gaza, though I think that does slip a bit. So even though Joe Biden said with one of the attacks on the maternity hospital in Gaza, oh, it was the other side, you do see the US now putting more pressure on coming from that. So why does it work? Why does targeting women in health and conflict work? Is it's women and children, you're hitting key vulnerabilities, you're saying nobody's safe. But also, as Rima Botman was saying about building feminist solidarity in Palestine, it's about killing future generations. You're not interested in just killing the current generation, it's killing future generations. How it also works is affect and how it connects to the public. So here I put the picture of Osama, the award-winning film. If you haven't seen Osama, I think it's one of the most incredible films I've seen in years. But I watched it again when I was thinking about this talk and finishing parts of my book, during the conflict in Gaza, and then it's even harder to watch. But it's an incredible film. We were just talking about, Emma and I were just talking before, it's absolutely so powerful, but it connects. And I think this image also, what you saw with affect, particularly in Ukraine, you saw that image of the woman being stretched out of Mariupol Hospital number 3, maternity hospital number 3. That was widely condemned, people saying, okay, what's going on here? So even though there's that loophole in international law, with the public, it's often seen as a turning point in how you understand these conflicts. Okay, so that's the first part of that. The wider question you see when you think about attacks on healthcare is attacks on healthcare workers and how is that gendered? Now, if we go back to thinking that 70% of healthcare workers in the world are women, if you see these attacks on healthcare workers, is it gendered? Now, I've talked to the experts on this. So they've got great projects in Johns Hopkins with Len Rubenstein's work, and in Manchester in the UK with Larissa Bass and Roisin Reid doing their attacks on healthcare worker projects. And as you might imagine, no one was looking to see if they were affecting women or men differently. And this is important because different attacks work differently. So men tend to be ambulance drivers, so that if you have sort of hold-ups at ambulance points, that's gendered towards men. Women tend to be more community health workers. We saw this around vaccination campaigns and those sorts of attacks. So it's really kind of understudied in this kind of way. It helps you understand the conflict, and it also understands what's happening in healthcare and some of the gendered elements around that. And what was interesting to me when I was doing the book is it's not just attacks against healthcare workers in conflict, but looking at attacks at healthcare workers in everyday healthcare settings as well. So seeing that as a normalised part of everyday work that happens, that people get attacked. And it's normally frontline healthcare worker staff that get it. And that's normally predominantly women. So that's why I was interested in thinking around this idea that attacks against healthcare workers could be a form of gender-based violence in how that work is devalued. So I would talk to nurses and they said, oh, they'll never talk to the senior consultant like that, but they'll come and threaten me, or they'll, and women, they're doing things like women do when they walk home from, the metro at night. They're buddying up and walking around hospitals together. They're saying who has to go in and see patients together. All these sort of micro adaptations that women make are happening in our hospitals and healthcare facilities. So there is that school of thought, it doesn't matter, all healthcare is being targeted, but I think it does matter as a deliberate tactic of war and intent, and also what that means for gender equality more broadly. All right, so what did this bring us all to? All right. Oh, I like depressing people on first thing in the morning. Women's health is not, so the main argument is like, look, women's health is not just a public health, women's health issue of domestic politics. It is rooted in global power dynamics. And the other ways I address this in the book that I didn't focus on here, but if you have more questions, I look at the new oil of data in health, how that works, exploitation of love and care, leadership and meritocracy myths, and the exploitation of community health workers. If I ever get a tattoo, I think it's just like pay healthcare workers, or the sick of it label, one of the two. You can't improve women's health without being attuned to global politics. This whole just add women, look at what they're up against, right? It's something much bigger than that. Women's health is also central to understanding international relations, either international development aid, but also conflict. And there's a pattern here of women's health being an indicator of political activity. So conflict, the rise of populism, failures of multilateralism, diplomacy, rising powers. There's a lot of ways in which these patterns get addressed. And I think it's time we take these patterns seriously. So I want to finish with one story of the Pink House. So the Pink House is at the center of US reproductive justice campaigns. Do you know what the Pink House is? Pink House is Jackson Women's Health Organization in Jackson, Mississippi. So Dobbs versus Jackson Women's Health Organization is the Supreme Court ruling that overturned Roe versus Wade. When I was in, that's my shadow, taking the picture. When I was in Jackson, Mississippi, I met the driver. The driver used to work as a defender outside Jackson Women's Health Organization, aka Pink House. But once Dobbs versus Jackson Women's Health Organization overturned Roe versus Wade, what did she do? As you know, abortion bans don't stop women needing abortions. They don't reduce abortions, they increase unsafe abortions. And access to abortion pills is tricky in some states, but activists still work the system, they still have drones, they still put them in the post. Sydney Calkin's book, Abortion Pills Go Global, is brilliant on this, I really recommend it. But the driver, she drives 1,200 miles 3 times a week to clinics in different states. She stops for snacks and pee breaks. She doesn't know the names of the people in the car needing help. She just does it because they know that they need help. She does it as she wants to stop women dying when they don't have to. And she sees it as following the path of the Underground Railroad, the J networks for getting people out of Germany during World War II. And the two things that was really clear when she spoke to me was that all the activists knew Dobbs was coming. They knew what was happening in Mississippi and how it would go further. Reproductive justice in the South was a mess. It wasn't just abortion, but forced sterilization of migrants. One ICE doctor, ICE, was known as the uterus collector. I think that wasn't in Mississippi, that was in a different state. And there was echoes of the Mississippi appendectomy that was famous in the Jim Crow South. So Mississippi appendectomy is free sterilization of African American women. And no one else was coming to save them. They knew what was happening and knew no one was coming to save them. And the driver, like the health workers I met in Palestine, the community health workers I've met across my career, and the women in Sierra Leone that I started this presentation with, all said something similar. Who else is going to help? And we could see this coming. We could always see this coming. They are spotting the trends, the international relations misses. And I think how we break this cycle then is seeing women's health at the centre of global politics, and we disentangle how these power relations work to understand them and call them out. Thank you very much. Yes.
Okay, well, thank you so much, Sophie.